Good morning again. The session 1 is the beginning of our learning session, and it is about reframing health systems and their assessment, reflecting on country-specific responses. I would request Dr. Krishna Reddy Nallamalla to join us, and he will do the context setting. As the moderator of the session, I request Mr. Maulik Chokshi, Deputy Country Director, Technical Access Health International, to please join us. We have 3 of our panelists and experts online and remote, and I'd like to recognize the fact that they are far away and in difficult time zones, but are going to be here online to be with us. Dr. Sohail Saikat, Dr. Sunam Kwon, and of course we have Dia here. So both of them will be remote, and we request you all to please come back with your tea for us to start the session 1 on learning. I am going, they're here, physically here. Okay. Dia, would you please come back up here for us? And I'm not reading the bios of people who have already been introduced to us. I request, yeah, I think you need to have a seat over here, you know, to be a part. Yes, please. Yeah. No, we'll get the tea for you. Latika, can you get some tea for Dia, please? May I request you to do that? Yeah. Bye. May I request Dr. G.S.P. Ranasinghe, Director of Primary Healthcare Services and Training, Ministry of Health, Government of Sri Lanka, to please come and join us. He actually works tirelessly at the Ministry of Health and has seen some very difficult times when there was political challenges and takeover during Sri Lanka, and how to take forward primary health care during that time was something that he has overseen. I'd like to request Dr. Lal Panapithya, I'm very bad at pronunciation, please excuse me, Deputy Director General, Medical Services, Ministry of Health, Sri Lanka. Both of them have traveled to be here with us, and who are also very, very involved in the change in times in Sri Lanka with the health systems. I hand it over to Dr. Krishna Reddy Nallamalla to take forward the session. And while I will still make a big shout out to all those people over there to bring their tea and come back inside for great learning that we are going to have and continue to have during this day. Over to you, Dr. Reddy.
Thanks, Uma. I think the first question actually the GLC took when it started last year, based on the members' inputs and other things, was to gain clear understanding of what we are talking of resilience. Because a lot of people talk of resilience, still it is evolving and it is still fluid, it's still ambiguous. In the context of that, again, to revisit what we actually understand by health systems. We have been using different definitions, have been using different frameworks. So that was one of the starting theme, even before it branches out into different elements of health systems. We started asking these 2 questions. In fact, the first session starts by illustrating some of those learnings that happened during the last 1 year. And then the panel will discuss with the different perspectives how they assess the health systems in the context of resilience. Because unless we know how to assess and what indicators we look at the health systems, we cannot evolve the policies, we cannot evolve the strategies, we cannot monitor whether these are actually improving the so-called resilience of the health systems. So with this background, I will try to share how it evolved briefly to set the context before I hand over the session to Maulik to discuss along with the panelists. Can I have the slide, please? One of the definition, because the definition of health system resilience was the most difficult one, because the different experts, the different context, what it started in the physics, in the field of physics, then later in the field of economics, later in the field of social sciences, the climate, slowly is talked about after the Ebola crisis and other crises as what is the resilience of health systems. We all know the definition of health systems in terms of its responsiveness to the people's health needs, in terms of the protecting from the financial hardships. But we always talked about the normal times. We never talked about the crisis times. That's how the health systems were designed, for normal times, but not for the crisis times. Their ability to respond during the crisis and absorb the crisis and then adapt and evolve from the crisis. So the group, I mean the GLC group with experts' feedback and the literature review, the entire process of the knowledge learning process, try to summarize some of the understandings into this simple definition of ability of a health system to ensure that access to high quality and affordable health care is safeguarded and guaranteed irrespective of the shock. And in order to achieve such a state, the system needs to prepare during normalcy, absorb shocks during the crisis, transform and learn from post-crisis. So this attempts at what are the key elements of the resilience. It is not another target or another goal. It is a key intrinsic attribute of a health system that is desirable. I mean, just like we talk about strong health systems, the resilience is an intrinsic attribute that is expected of a health system, well-functioning health system. So based on this definition, I mean, as I said, we try to relook at the health systems. The building blocks has been the framework most often used, and we have been aligned with that. Only slight modification around that is that we are starting with the people in the center, the people's health status in the center. What is the people's participation in their own health systems? What is the determinants, the social determinants, the environmental determinants, what are the threats? So there is a refocus on starting with the people, understanding the people's health status, understanding their vulnerabilities, because any evolution of health systems is in response to the people's requirement. And these requirements are dynamic and they are changing. So that's why there is a session dedicated only to understand an actionable element of what do you mean by health literacy of people, what do you mean by the people's participation, what do you mean by the equity of health services in the people. So that is the center of the health system. And most of the health systems we always discourse, especially in the experts panels from a global level. Most of the discussion is in the global level, but health systems evolve from the local level. They evolve from the local level, then they go to the district level, the state level, what is the national level and the global level. So unless the health systems functions are looked at different levels in the different context, we may not come up with the suitable solutions for that level. The financing at a global level may be totally different from financing at a local level. Financing at a state level may be different from the financing at a national level if it is a federal structure. So articulating health systems at different levels is, I think, one of the key theme that is trying to be depicted here. The four core functions in terms of responding to the health needs, the provisioning function, divided into two sessions actually in this annual conclave. One looking at the population health needs, that is the public health, and one looking at the personal health needs, that is the healthcare provision. So these two are being discussed because the public health actions, public health management, public health approach is totally different, and the competencies need to have the population health management are different compared to the personal health management. We cannot equate them both. At a medical personal health care management, you are an individual patient, you are articulating with the individual patient. The individual needs may be different. So that's why the provisioning is taken as a prime example of that. And of course, for any provision, you need the supply of resources, the human resources, the material resources, the technology resources, the entire ecosystem of the resources, from the research, the development, the manufacturing, the supply, and the storage, and the consumption, and the disposal. All these things, unless they are looked at as a total ecosystem and in building the resilience of this ecosystem. And third is the financing of these resources. Because this is how the financing comes into the picture. It is not just the money. I think the money has to translate into the resources. Money without humans, money without technology, money without goods is no money, because it's useless. So that's where I think the finance follows the supply of these goods and resources. And finally, to manage this entire complex health system, which is fragmented, interlinked, interdependent, it's dependent on other social systems. We do not have the competencies, well-defined competencies to manage, govern these complex health systems. I think there is a need to define what are the competencies required to manage this governance system. And I think one session focuses entirely on the very concept of governance, that the governance is not government, it is the triangle of people, the triangle of private sector, triangle of public. So it's a triangle. Each one has a right, each one has a role, each one has a responsibility, and accountability follows that. So if this definition is there, what is the responsibility of the private sector, what is the responsibility of civil society, and what is the responsibility of the government? Because we always equate accountability only with the government, not with the private sector, not with the people. So the governance ideally should equate all the three angles of the triangle. So that's why the triangle is brought into the two triangles of governance, that is public, private, and the people on one side, in the form of the laws and the policies, and the provider, payer, and the people triangle is another triangle of the governance, because there is a power play between all these three actors in the governance system. And how the power play shifts, how the responsibility shifts, and how the communication flows across these three actors, and how the relationship is built across these three actors defines the triangles of the governance. So this is how the governance triangles have been articulated in this depiction. And following that, the less importance that is given, because the systems are totally fragmented. However, they're interdependent, they're dynamic, they're continuously evolving. We don't give importance to the three linkages, the critical linkages, that is information, communication, and the relations. These three linkages usually are not given as much importance as part of the governance system. So we try to bring these three linkages, that there has to be a focus on, already there is a focus on the information systems. How do we actually harmonize the information system? How do we integrate? How do we interoperable information systems? But we don't give importance to the communication, which was very evident during the pandemic, that the miscommunication, how do you counter the miscommunication? That spreads across the social media. So there has to be a thought process in terms of how do you communicate to the people at the local level from the global level. Similarly, the relationships, even within a country, the center-state relationships, even within the government, the Ministry of Health, Ministry of Finance don't talk to each other. And within the Ministry of Health, NHA does not talk to NHA. So this relationships, why we don't give the importance of the institutional mechanism to build these relationships. So we thought the framework should have equal emphasis on these three critical linkages, which are essential to harmonize the complex health and social systems. So I think this expands on the building blocks concept to include these as the most critical elements of that. Then going forward, so that's why it is linking up both horizontally as well as in the vertical lines. And the final framework actually depicts the globe behind the framework. That means the human health is not in isolation. The human health depends on the plant's health, animal's health, and the planet's health. So the planet, that's why, is depicted as the background of the entire health system. That means health system does not exist in isolation. So this, I think, a brief summary of what actually evolved through the process of that learning journey that happened in the last 1 year. Not many people were involved, both the members of GLC as well as Access Health team and experts from WHO, experts from London School of Economics. So I think it was a good journey. I mean, this is what the GLC could bring out, but this will, I think, continuously evolve. We don't want to make it as a fixed framework, that the dialogue should add some more elements or delete some more elements or modify this conceptual framework. So this is open to kind of modification. In fact, the panel discussion should lead to that. I hand over to Maulik to take it forward with other panelists on discussing how they perceive. I'm not covering on the assessment aspect of it. You take over on that. Thank you.
Thank you, Dr. Reddy. So I think so, the task given to me, I think so, is now linking this broader thought process into how do we assess it. And I think so, there needs to be a variable that needs to be able to measure each and everything. And I think so in this context, we are privileged to have kind of 5 colleagues with us. Starting with Dr. Sohail Sohail, he is the lead health system resilience at WHO Geneva office. And I think so WHO Geneva is also working extensively in creating health system resilience framework and toolkit to kind of measure at a systemic level what does it mean by resilience, how do we measure it. So Dr. Sohail, can you hear us? Dr. Sohail? Sir, you are on mute. Can you hear us?
I can hear you. Can you hear me, Maulik?
Yes, thank you. Loud and clear. So, Dr. Sohail, you heard the opening remarks by Dr. Reddy and your experience of evolving health system resilient measurement toolkit at WHO Geneva level. So, for me, I would like to kind of explore this idea. There is health system assessment, right? And which has been part of our system for a long period of time. And now we have got health system resilience assessment, right? Now, firstly, how to differentiate between health system assessment, health system resilience assessment? That's one thing that we would like to explore through your experience. And second thing that we would like to explore is that obviously countries are on different level or different trajectory or different maturity level of systems resilience or health system assessment as well. So how do you measure the maturity of countries as far as resilience are concerned, and what could be the challenges at the country level to do kind of resilience assessment? These are 3 kind of directional questions to you, and I will hand over the floor to you. I know you have a small presentation, so we are ready to take those things forward. Dr. Sohail, the floor is yours.
Maulik, thank you so much, and sorry that I unable to join you all in person, but I listened the context presentation. Very impressed, I think, with the content and also the very exciting agenda that you are executing. So, Maulik, I think I will try to answer your questions, and I put some slides, and I believe I believe you can see them here now.
Yes, please.
I think you talked about the different countries' maturity. I think these are all basically related to different demands and stressor of the health systems. So we are all still in middle of COVID-19. I think is still here. I think it has got that multi-sectorial impact. But we also know that there is a significant backlog of health services due to focus on COVID-19. But at the same time, we know that there is a globalization. There are many
recording in progress
in conflict and war. And I believe you mentioned also climate change. There is a antimicrobial issues. So there is a varieties of stressor and demands on the health systems. But in the end, it's basically a one health systems that we need to depend on to provide all types of services. But often we try to see the health systems from a different viewpoint. I think, for example, the groups on climate change, they want to look at health system from their own perspective. At the same time, if you look at the NCD, they try to look at NCD for health systems, but these issues is basically draining the resource, is basically not uniting the limited resource that we have to build the foundation and a strengthening of the system. And in global level, I think, except, for example, countries in humanitarian context, I think there is a very, very siloed and fragmented approach. There's a big movement on health emergency preparedness and response, and under international health regulations as well as global health security agenda. There is a traditional health systems strengthening, looking at 6 building blocks, and there are also a number of vertical disease and life course specific programs. And then if there are countries in humanitarian context, for example, countries like Bangladesh, I think in Cox's Bazar, and there are countries in MENA regions, in Middle East and North Africa, now parts of Europe, there is a huge investment on humanitarian side. But often there is no coordination between all of these vertical investment going into health systems. So when there is an opportunity to synergize, opportunity to bridge the different investment into program and planning, but this is not happening yet properly. So the issue is that the legacy of the investment sometimes become obscure due to lack of integration between all of these vertical objectives that we have. So this picture, I think, is a global one. And if you look at the second row on the right-hand side, I think that is the WHO's pulse survey that we conducted in the course of COVID-19. And the reason you all know that is because a routine health information system was unfortunately collapsed. In countries in most income group, it was not just countries in low income setting, it was a significant disruptions in health information system to report on this service availability, whether for COVID as well as for other essential health services. I think 92% of the respondents in the survey reported disruptions, and the overall median of disruption, it was around 45%. And then if you look at the figure on the first row on the left side, that is the financial barriers one. And I think it's a crowded picture, but if you look at it, the issue of the access to health services, it was widespread. It was not an issue in countries in low income group. It was present also countries in high income group. I think many people spend more than 10% to cover their medical cost, 10% of their income to cover the medical cost. And it was not just because of COVID-19. There are also supply issues. COVID is one of the reasons, but there is also a major financial difficulty to access quality health services. And then if you look at the picture on the first row on the right side, I think that is another very, very important one. I think that picture gives some very, very unfortunate fact. 3.16 billion people cannot reach a healthcare facility by foot within 1 hour. 8.9% of the global population, which is around 646 million people, cannot reach healthcare within 1 hour, even by using motorized transport. And then if you look at the picture on the second row on the left side, I think there are examples of countries that are unfortunately caught up in humanitarian context because of war and conflict, because of the population displacement. I think the message that I wanted to convey from here is that we cannot expect to achieve universal health coverage if countries continue to suffer from the impact of disruptive emergencies. At the same time, we cannot expect health security if sizable population remain outside of the health services. I think the fact is that in that case is that the surveillance, contact tracing, diagnostic reporting are going to be delayed if the people do not come to get the service from their health systems. So, colleagues, given the focus of the discussions, I think is on the assessment and monitoring. So, this is the current global perspective in terms of countries' performance during COVID-19. So, there are three figures you can see. One is a correlation between Global Health Security Index and COVID-19 death rate. Second one is something we have been coordinating from WHO, as a WHO with many of our member states. Some are from the Global Health Security Agenda, is the joint external evaluation and COVID-19. And then the other one looked at the US index. There are two indicators that we have for measuring countries' performance to universal health coverage, financial protection, and access to quality services. I think the message that you could see from here is that there is no correlation between countries' performance in health security preparedness and their performance in reducing mortality and morbidity to COVID-19. Similarly, even countries that has got a better service coverage, for example, countries in Western Europe, countries in some of the South Asian countries, as well as countries in the East, I think there is no correlation that they did better to maintain their routine essential health services while they are responding to COVID-19. So what does it mean? It means that the current way of assessment and monitoring the performance of the health systems, that there are some proper gaps, the way we try to indicate the country's capability. And it also indicates that the investment and the programming to develop the capacities are probably failing to develop the baseline health systems capacities. At the same time, for adequate public health orientation in the way systems develop, in the way coordinations should take place. So I think my colleague before, he presented the conceptual aspects of the resilience, I think from a planetary point of view. So we as a WHO did not intend to come up with a specific definition, but we tried to look at all the global definitions that are available on resilience, and we're trying to extrapolate the definitions in reference to health system. I think the overall messaging, I think, is similar. I think is the capacity of the systems its ability to forecast, prevent, prepare, and respond to versatile health systems stressor and demand. And while it do that type of management of stressors and demand, we want the systems to maintain the essential function in all contexts, and then recover fast, and also translate the lessons learned so that it can do better in the future. So there are four the indicators that we developed from WHO, which are going to be released very, very soon. We try to capture these four purposes of health system resilience: ability to forecast, prevent, and prepare to stressors and demand; ability to maintain the delivery of routine and essential health services, ability to absorb, adapt, and respond to challenges, and then how we can translate the lessons learned. So if you look at the figure on the left side, as you, I think is we can relate us the COVID situation as a first shock. I think if you look at there are two red sign. So first one can be we can relate to the current COVID situation, and we can generalize countries that due to typical investment, there has been improvement in health system. But then we had COVID-19, the health systems are disrupted, and now there is a period of stabilization. Many countries are trying to recover in terms of clearing the backlog of services. They are trying to recover from the multi-sectoral impact caused by COVID-19. So the lessons and the intentional input from a resilience point of view is that we need to do something differently. We need to have some intentional investment in making the systems resilient in workforce, in supply chain, in information system, in coming up with an enabling policy and financial environment, so that if there is a future pandemic, there is going to be some level of disruptions. But the way we can measure the dividend of resilience and investment is comparing how a country performed, for example, during this pandemic, and also if there is another, unfortunately, a pandemic. So we can measure it in terms of population health point of view. We can also look at from a multi-sectorial point of view, impact on the economy, impact on the social disruptions, etc. And then the ultimate objectives is to maintain the services for all, regardless of their income group, regardless of their the situation, the context that they are living. So colleagues, I believe you came across a toolkit that we released last year from our team in Geneva by working with regional office on health systems resilience toolkit. I think the objectives of that toolkit is to capture the global state of knowledge and tools that are available into one reference as a compendium. So one of the gaps that we identified is that how we can measure resilience in health systems. There are so many measurement approaches available, but we couldn't identify, Maulik, a dedicated tool for measuring the resilience of the health system. So that was the genesis of the work that we consulted with you last year, and now the work is in an advanced stage. So colleagues, you all know that in the global architecture as well as country architecture in terms of assessment and monitoring, so there are tools, that exist from international health regulation. There are tools are also available from health system side. There are also tools available from other vertical programs. There are also tools available in the context of humanitarian response. So the objectives that we had is that due to the gap is not to complicate, not to duplicate any other tools, but how we can come up with a unified focus to measure health system resilience. And for the first time, the tool that we are developing is going to look at the maintaining the health services, at the same time ability of the system to maintain the resilience capacity to prevent, response, and recover to a disruptive emergency are captured. So unlike other tools, we are focusing on services, but at the same time, we are also trying to support the countries how they can also measure their performance to prevent, prepare, and respond to an emergency. So the approach, colleagues, that we applied to develop this indicators package, we, like any other tools development, we conducted a systematic literature review. We looked at the existing database and inventories of indicators, and we have been consulting with experts. So this is a very brief trajectory how we developed. So the different sources that we exhausted allowed us to come up with a total of 830 indicators related to health systems resilience. We removed the duplications, and there were 398 identified as a duplication. And in the second stage, we came up with a total of 432 indicators. Out of 432, we consider 173 indicators feasible for applying at country level. And out of 173, at a 65 identified as a core indicator that can be applied in health systems to measure the resilience. And we organize them, as you have seen, as you could see here, according to 6 building blocks of health system. But at the same time, there are special considerations about some of the cross-cutting one. For example, general composite indicators, as well as we put 6 indicators exclusively also on community engagement. So so this is the architecture of the overall presentations of the indicators that we develop. I think the objectives, again, ability of the health system to forecast, prevent, prepare, and respond to public health stressors and demands, maintain essential function, not just the individual health services, but also population-based health services, and to recover fast and also improve for future stressor. So we organize the indicators according to building blocks and as an inputs, and then also we had the indicator to measure the processes and output. So the all 65 indicators are organized according to this architecture, and the overall outcome is the universal health coverage and health security, and the impact also related to our sustainable development goals. So each of the indicators, I think the information organized in a systematic way. There is a short name of the indicator, and then there is a full name of the indicators and how an indicator relates to building blocks, and then the full definition of that indicator and the rationale why we chosen that indicator related to resilience. And then we also disaggregated whether the indicators related to national level capacity or subnational or facility level. And then like any standard indicator, we also tried to identify the denominator and numerator for that indicator, and also the data source that can be utilized, as well as the reference and existing data collection tools. So this is one example. In the interest of time, I'll just pick this one. So here we talked about health sector plans. Most of the countries globally has some types of health sector plan. Sometimes they call it health sector strategic development plan. So this indicator would like to see how typical health sector related plan also include emergency capacity development. This is due to the fact that many countries' health sector strategic development plan do not have explicit consideration for health emergency preparedness capacity development. I think that also contributing to the fragmentation. For example, on the health security side, many countries adopted National Action Plan for Health Security, which is also good, but what we would like to see that there is a proper alignment and integration between health sector strategic plan and emergency related plan. So there is a full indicators name, as you could see, And this is related to governance and leadership. And then we have a long definition of the that indicators, and we put the rationale why it should be there, and then whether it's a national level or subnational level. And then the recommended data source, it could be document review, and the structure and the additional reference why we consider this indicator is important. For example, the WHO's positions for recovery asking for an integrated approach in health systems strengthening for achieving both universal health coverage and health security. And then I think this is an example of the indicator related to financing. So here, for example, we had percentage of facilities with user fees waiver mechanisms. So this is related to universal health coverage, but is an important one. If there is no fee waiver mechanisms, if someone got sick, unable to pay, there has to be a way for this person to get the required medical care that he needs. Otherwise, he will not come to the facility. If he or she doesn't come to the facility, that means the identification of an event, the diagnostic of that event, surveillance of that event, contact tracing of that event is going to be delayed. So this is where the inevitable relationship between universal health coverage and health security. So whole indicators name you could see here, percentage of health facilities in a country with user fees waiver mechanism for public health emergency related health services. So this is linked with health financing, the building blocks, and then you could see additional details. So all 65 indicators has this metadata attached to it, so that any country, any partner authorities, when they work with the member state, they can guide how it can be operationalized as part of the routine health information system. I'm not going to go into this one, Maulik, and colleagues can have access to the slides as well as the full package of the indicators. So colleagues, I think we can cover the next step, I think, as part of the discussions that we will have now. And just to Maulik's your questions about the, I think you put two questions. I just want to summarize the two questions that you put. One is the difference between health systems assessment and health systems resilience assessment. I think there is from my own personal viewpoint, I think they are related. They are related, but the need for coming up with a resilience specific indicators, because it brings two sides of the coin together, is an indicator that would allow health systems to measure their progress and maintaining health services, but at the same time, it will allow the health systems how it prepare to manage and disruptive emergencies. So the indicators that we are developing, it can serve dual purpose under each of these indicators. The second part, I think you mentioned about the country's maturity. So yes, I think that is quite is the reality. I think in the WHO's GPW 13, which is also going to be manifested in GPW 14, as well as 100-day challenge that we adopted, I think we are trying WHO support to countries depending on their context and also maturity in the health system. Some has got a considerable foundational issue under different reasons, like the context of fragility, conflict, and violence. And then some countries has got some level of capacity, but the institutions are weak. And there are some countries has institutions are there, but they need technical support. And some countries, WHO support is more in terms of policy, so that there is a proper financing, there is a proper public health orientation, there is a proper multi-sectorialisms are built in. So we are aware of it, and we are trying to come up with a differentiated approach to organize WHO support with our partners at country level. So Maulik, thank you so much. I stop here and happy to participate in the discussion.
Thank you, Dr. Sohail. A fantastic presentation and clearly outlines the differential between health system assessment and health system resilience assessment, and the need of differential capacities and different inputs based on the capacity of the countries to measure health system. Let me go to Professor Suwon Kwon, who has joined us from South Korea. Professor Kwon, I think so at a global level, when COVID struck us, I think so one of the country which was looked towards in kind of adopting strategies to mitigate health system fragility or to kind of respond better to health system need in time of emergency was South Korea. And everyone knows globally, I think so the way the digital architecture has been created by the government of South Korea to kind of a seamless flow of data. In your experience from COVID, I think so, I'll pose the same question, difference of resilience versus system assessment, and what are the learnings that we can have from Korea when we start talking about how systems needs to evolve to be more resilient from what they are, and what additional things that they need to do, because 6 building blocks adding are something that we are all working on. What additional things need to be done, and what learnings can we have from Korea as part of various efforts they are doing? Professor Kwon, and we've got, sir, 10 minutes. I'm sorry to put you the time limit, under 10 to 12 minutes for this. Thank you.
Thanks a lot for inviting me to this panel. Let me briefly overview some existing health system components related with this COVID thing. And then I'll give a few kind of additional reflections from the Korean experience. First, I think we all know that preparedness is very important, and Korea was, in a sense, a bit lucky because we had a MERS experience. Probably, I mean, except for a few Middle Eastern countries, there are not many countries in the world that experienced this MERS, I mean, Middle East respiratory syndrome. And then at that time, some mortality from this MERS in Korea was a bit shocking event. So, but as a result, government strengthened the Center for Disease Control. I mean, expanded the budget, expanded the capacity personnel. So, that type of policy learning from previous failure was a good part of the good preparedness. And also in terms of governance, I think there's a rather smooth collaboration between central and the local government. And because many local government, they are not have enough capacity to handle these issues. So most of this provincial local government, they follow the guidelines and directions provided by Center for Disease Control and also central government. And at the central government level, there is a high-level government committee led by Prime Minister. I mean, Prime Minister in Korea means the Vice President. So Vice President was the chair of this national committee, and all relevant ministers joined the meeting, and major decision-making was made at that. And also, UHC is still very important because the testing is fully covered, it's free testing. And also for treatment of COVID-19 patient, they did not even pay copayment because copayment paid by the government. But, Korea has the national health insurance system covering everybody, but we had copayment component. But in the case of COVID-19, there's no copayment. It is funded by the government budget. So in terms of the interruptions of essential services, I think there's a bit, not a huge problems of disruptions of essential services. But also, as you know, there are challenges. For example, the majority of Korean hospitals are private. So in theory, National Health Insurance Service contract with all public and private hospitals is mandatory. So in theory, private hospitals, they should join the treatment of all COVID-19 patients. But it is also true that private hospitals, they provide all possible excuses like, okay, there's no empty beds, it's full, that kind of excuses to avoid treating the COVID-19 patients. So as a result, you know, in Korea, less than 10% of the hospital are public, but they treated the majority of COVID-19 patients. So still the collaboration with private providers, health providers, it is a challenge in this COVID-19 era. And also, there are some components which is not easy to. It's not really tangible thing, but some kind of intangible or not easily measurable component. I think I call it kind of agile policymaking or agility in policymaking. Of course, it is not easy to measure this very important aspect because we know that preparedness is very important, but we always face a slightly different types of pandemic, disease X in the future, I guess. So even with a good preparedness, we still need some kind of rapid response capacity. And then the key component is agility in policymaking. In other words, we have a good governance system, and we need the policymaking system that is based on evidence. And as we all experienced during the last 3 years, there's new evidence every month, every day, basically, right? Then government should be ready to, or government should be willing to modify the policy based on new evidence. And also, we experienced that our own policy failed in some cases. Then we should be ready to correct our policy based on these failures or learning by doing. Okay? So we need a evidence-based policy-making process and also learning by doing process. And that kind of agility in policy-making, I think is very important component, but often neglected because when, especially in the healthcare sector, most of the discussions are very technical. And you know, I'm an economist and social scientist, and for me, this type of policy-making capacity is very important. And also, we need some kind of, we need two separate approaches. You know, in a technical committee, we need we should deal with a lot of technical aspect. But we should not forget that this pandemic is not really a medical problem. It's not really only a health problem. It's broad socio-economic issues. And also government policy, like a social distancing, lockdown, that government policy has an impact not only on mortality, morbidity, but also on the human nature, on our society, on our economy. Then the policy framework has a good balance of saving lives, but at the same time, saving livelihood. But unfortunately, I found that the health sector experts tend to focus only on saving lives, saving morbidity issues, a bit neglecting the saving livelihood issues. You know, I deeply involved in the government policy of COVID-19 for the entire time period. And then this is my own reflections. And for example, the school closures, many countries, including Korea, I think that we shut down schools too early and too long. Because if you focus only on like an infection perspective, maybe we have to close the school. But if you have a longer term human development perspective, then I think we should not close the school that early. So what I'm saying is that we need a bigger or more comprehensive policy perspective, focusing not only the mortality, morbidity, or health impact, but also a broader socio-economic impact. And as you know, the livelihood or economy is important because the economy will have a long-term impact on health. So that is a bit related to these assessment issues. I fully agree that existing assessment have a lot of weaknesses. So we need to develop a new kind of measures. But again, when we develop measures, you know, I also develop some measures for WHO. But when you develop measures, we derive some desired aspect based on the criteria such that if we have this desired characteristic, desired aspect, then we will have a positive impact on our resilience. Then my question is how to measure the resilience. There are many different aspects. So we should not neglect the aspect that how to achieve the resilience. What is a sacrifice in the socioeconomic system? So when we view this resilience, we had a broader perspective, taking into account not only a kind of health sector perspective, but also from a socioeconomic perspective. And so in other words, we achieve this resilience through what process, through what socioeconomic benefits and cost. Okay. And also that relates to the question of how we move from the current status to the ideal status of good resilience. We may need a political economy thinking. We may need a qualitative thinking, because when we have a conversation or policy learning among countries, it's not enough to show them, okay, this is the way, this is the way we should go, and this is the aspect you are lacking, you should improve. But many countries may face their own political economy barriers to change, improve that aspect, to improve the resilience. So, I mean, we need a broader policy perspective. Over. Thank you.
Thank you, Kwon. I think so. If you start looking at social capital perspective, I think so. Measuring beyond health system perspective is very, very crucial, and I think so. That's boundaries that when we talked about health system assessment or health system resilient, and not kind of looking at the social, socio-economic or political economy factor that affects health system as a whole. And hence what Dr. Reddy presented earlier, that global ecosystem is very, very important, because at a health system perspective also they have got direct kind of effect, measure that affect the kind of health outcomes. Kwon, I'll come to you, because I think so when you talked about agility of health system, how non-tangible, not measurable, and so I'll come to you on that question after getting hearing from Dia. I think so. Indonesia had done something a bit better in terms of getting communities and those as part of our kind of response, government's response when we talk about strengthening health system. So can you share, hearing Dr. Sohail and Professor Kwon, did we do something different in Indonesia when we responded to COVID? And when I say, if you want to put Indonesia into kind of health system indicator scale, where would it stand? What are the factors would have kind of assisted in getting in that shape?
Okay, thank you. Okay, thank you. I think the previous two perspectives presentation is very interesting and very spot on. I guess as a country, Indonesia was not placed differently than any other country during the first or the early months of COVID. Everyone, the whole world was taken by surprise. Some countries were in a better position because Dr. Suhail presentation pointed out that resilience should be prepared from normal times. I think other countries are more prepared because they were prepared, not for the pandemic in particular or per se, but it's the health system itself is approached consciously to be prepared for any external shocks, whether it's pandemic or an outbreak, an isolated outbreak. No one was prepared for the scale of this pandemic. So Indonesia, I think, is the same. When the pandemic first broke, none of the health workers who work in primary health care were prepared. They didn't know how to do the SOP for this disease. It's very new. They don't know what to do, but problems keep coming in to them first. So knowing that situation and the unpreparedness of the primary health care system, the government then supplemented that with hospital. So most of the care for COVID patients, instead of being separated into preventing those who are still well enough to be isolated at home or being taken care of by primary health care, all went directly to hospital, because the health workers at the hospital were perceived as more knowing, more knowledgeable. The life-saving aspect is there. But again, the livelihood was not there. Preserving livelihood was not there. And I think Indonesia, if you want to compare the score from the joint external evaluation, hit the 63% mark on paper. But when the actual thing happened, it didn't look like it hit 63%. Everyone was surprised, didn't know what to do. From the government level, from policy making, governance perspective of COVID response or health emergency response, everything was almost being done hastily and without enough preparation. The lead for COVID response is not in the health sector, not directly by the President's office, but by another coordinating ministry. Yes, there was a setup for the task force of the pandemic response, but and they are good to reach out to the level of life-saving again at the community level, but not as far as preparing the health system to be able to deal with the everyday, from simple information seekers to referring people to the hospitals or separating into the isolation is not being done. And I think what the months provided with experience and with more knowledge as the pandemic continue, it is sad to say that lives have to be lost as the cost of learning. And if at that time the primary healthcare system was more robust, because Indonesia has 10,000 public-owned, government-owned community health centers, and another 10,000 private-owned clinics, private clinics, that can actually make a very strong community primary healthcare system. If that system was strengthened from even before the pandemic, then lives wouldn't have been lost. So I will separate the perspective of policy and will give the benefit of the doubt that as policymakers, it's very difficult to fathom that such crisis can extend for such long period of time. It is very difficult for policy, a very difficult situation for policymakers. But also, at the same time, there are lives of people depending on the capacity and the capability of policymakers to recover quicker from the shock. And as civil society organization, we measure where we will be best benefit for the community, of course. So we take sides with the community, strengthen the community, and not only communities directly, but also the health workers and the community health workers, because they need as much support as communities themselves. Us as the beneficiaries of health services require service from our nearest community health workers, our nearest health workers at the primary healthcare clinics. I think the implication or the reality from the 63%, the unmet or the unrealized 63% of the JEE external evaluation, I think that's the impact that the community is suffering from.
Thanks, Dia. I'll come back to, I need to probe more on the community participation and its own resilience. Sir, before I come to you, Dr. Sohail needs to go for another meeting. So are there any burning questions for Dr. Sohail from WHO before he leaves us? Any burning question that we want to ask Dr. Sohail on the differential with system assessment and resilience and the indicators, the 8 system indicators. Any burning question? Or else what we can do, you can drop us the question later on and we can ask Dr. Sohail and get a response back. So there are 2 options. So if there is burning question, please, or we can thank Dr. Sohail for his participation today. Yeah.
Initiated by the WHO, and we have to appreciate the thing. So then we would like to actually, thanks for the Sohail and presenting to us, and we would like to actually in Sri Lanka, so if it is doing a pilot
Sure.
for the, so we can
Yeah.
would like to participate. So that it's a very comprehensive thing. We will better to improve actually through the pilot.
So Dr. Sohail, I have a question for you, and I think it emerges from what Professor Kwan did say, right? If you start looking at the social capital theory, right, health itself cannot be looked into isolation. So the potentiality, when we evolved this toolkit, was there any discussion about getting tools, getting indicators on livelihoods and those getting as part of, I wouldn't say financial risk protection, but I would say social protection? Were there any discourse and do we measure those indicators as part of our financial risk protection or social protection in general? Before I leave you, and thank you.
No, thank you, Maulik. I think that this is very, very important in terms of the wider aspect. But 2 things I need to tell you. One, why we failed during COVID-19. I think we failed during COVID-19 because of for 2 reasons. One, the way country developed their health system, it was, unfortunately, in majority situation, it was more of a capitalistic model. It's a hospital-centric health systems development. So the primary care approach and the public health orientation was unfortunately absent in most countries. I think, so the result was, as we have seen, very quickly hospital was oversubscribed and hospital collapsed because the primary care approach did not apply. And even if there is a primary care built-in health systems, because of the lack of public health orientation, so they also became out of service. So the failing, and if we wanted to improve from COVID experience, I think we need to come up with an approach to make the health systems resilient and also journey towards self-reliant. So health system needed to have the ability to do its own business, because the current model, if you look at even countries that perform reasonably well in terms of reducing mortality and morbidity, there is a high economic cost. And the government has to bring all assets, not just from Ministry of Health, from other line ministries, to assemble the resource capital and assets to mount a response. But this is not an affordable solution. This is an expensive model of response. So in the moving forward, we cannot afford similar model of response. We need to come up with a more strategic, more lean approach. So, but that approach needs some short-term intensive investment in health system with a public health orientation, so that the same health system can tackle its own problem before government needed to involve, before government needed to bring other machineries. So that one. Second one, I think this social capital one, I think there is another WHO movement, and we need to also develop a better bridging between our own WHO system. I believe you came across Universal Health and Preparedness Review, and from CRO we had Thailand. I have a colleague, Dr. Mac is speaking. So I was also part of the USPR, and then Thailand also participated in second round of JEE. So the simple objectives of USPR is, I think my colleagues who also presented this social capital aspect. So what we are trying to do in the scope of USPR is to delineate the issues in a country between the activities, between the problem that can be tackled within the authority of Ministry of Health, but at the same time, trying to identify the priorities that would require beyond Ministry of Health's consideration, like heads of the government, Ministry of Finance, Ministry of Planning, Ministry of Labor. Because in Thailand, I believe it will come out from Dr. Mac, there are some very, very good examples about multi-sectorialism. So, social protection aspect, how we can perhaps institutionalize them as a SARS option for future pandemic. So in the context of USPR, we are trying to come up those issues and trying to ensure that multi-sectorialism can be institutionalized so that we can build on it when there is an emergency happen. For example, these financial protections, the contingency fund, and bringing the labor protection issue, the issues of the refugees, issues of the migrant, and making them accessing the health services, etc. So these are broader issues, but the fundamentals as a health communities, I think we need to have a journey for self-reliance, and we need to make our systems in a way that a small emergency can be tackled effectively before it can become a big emergency in a national context. Otherwise, the global operations, I think, is going to be continue to be an expensive one. Thank you, Maulik.
Thank you very much, Dr. Sohail. Again, I appreciate giving us time early in the morning. I know it's 6 o'clock and 7:30 a.m. in Geneva right now, but thank you very much for giving us time, and we'll keep on exploring. As colleague from Sri Lanka said, we're interested in knowing how do we pilot the resilience toolkit in Sri Lanka, and I think a lot many partners sitting out in kind of from various countries would like to do that and see that how those indicators could be further improved. Once again, thank you very much on behalf of Global Learning Collaborative for Health System Resilience for your time, and from XSF International at Rockefeller, and we'll stay in touch. Thank you. So I go back to colleagues from Sri Lanka. Sri Lanka faced kind of two shocks. I think so most of the conversation still evolved around health. But Sri Lanka, a couple of years back, had climate kind of shock, they get health shock, and now recently they got economic shock as part of the dealings of government. So if I may ask a question to Dr. Lal, how does government kind of respond in kind of, there are various kind of shocks, and I think the latest one kind of drives out the whole financing that's available for health sector completely. So in those kind of situations, how does the government kind of make their systems more resilient, or make sure that the services are still accessible to people? Thank you.
Thank you very much, actually. And first of all, I would like to thanks to organize such a this kind of forum and inviting us to share our experience. So then actually COVID destroyed our health system, economy, and the social status. So then, but anyway, this is the good aspect of the COVID. So then we are together here to discuss and share our experience to develop our own health systems in all the countries. And so then in the COVID-19, and also then thereafter actually developed the financial crisis. So actually we have a good health system in Sri Lanka. So then it's managed by the our own health minister, and also that leadership actually given from the even top level, the president level. So then there are all the health institutions, our network, the preventive and the curative. So then and they are managed by the centrally. So then that's the main reason actually that it was the main reason to get the success actually even during the COVID period, and even this crisis, even the crisis situation. So then it's this type of mechanism. So then this type of structure was very helpful. So then this crisis situation. So at the moment, so we are maintained even during the COVID period. So we had, I think, as for all we had the main target, main objectives to maintain the, develop the facilities for that type of crisis, even COVID patients, and then maintaining the normal patient care services, and also the protecting our patients. So then similarly in this crisis, so we are maintaining our routine health care as far as possible up to the acceptable level. But anyway, that we are in a major crisis actually for the supplies of medical items. That's the main obstacle actually we have. And with the support of the other development agencies, and also the well-wishers and the other donation, individual donations we are managing so far. So then when we cut down the cost for the lab testing, unnecessary lab testing and unnecessary, and we revise the drug list, most of the time actually cancer and the other things. So according to the essential items, so we identified, we concentrate mainly for those items. So then other thing actually we concentrated more to develop the primary health care level. So then rather than actually, so we expanded more and more to the secondary care level and tertiary care level, and we upgraded those. So then, but anyway, that most of the time the primary care level was actually underutilized. So then we the concentration was given again to develop the primary care level, more to actually attract the people to the primary care level for the, and even in emergency management, and also that family developing family care clinics, reverting back to the patients, concentrated in the secondary care level and tertiary care level clinics for the follow-up. So we will actually may send him back, refer him back to the primary care level. So then the family medical clinics, and also other the stroke patients. So then rather than actually managing in the highly crowded tertiary care, secondary care level, so then after initial management we are sending them into the step-down hospitals in the primary care level. Those aspects actually we so those initiatives we have taken, and even during the COVID period. So then the main thing, so the planning was the major part actually that we achieved. So then with the initial phase, so it's identifying the screening the patients and isolation, and also that the quarantine. So we concentrated. Then second level, second wave, we identified most of the time, so the patients are asymptomatic. So then we use, rather than actually utilizing the tertiary and secondary care level affecting the normal patient care, routine patient care, so we concentrated the underutilized primary care institutions for the management of the mostly the asymptomatic patients, and developing the centers for the management of the symptomatic patients. And third wave, actually that we opened all the hospitals, major and other hospitals, for the screening and identifying the managing patients, and not even that, actually that we couldn't bear, the whole hospitals couldn't bear the influx of patients. So then we developed the home-based care management, and so then the asymptomatic and mildly symptomatic patients were kept their home and with the comfort of their own home, and but actually monitoring through the medical teams through mobile connections. Okay, so then develop the call center facilities, and then thereafter, and also with the step down, identified the step down hospitals. So then once managing the critical patients, so then they up to one level, so then they will be transferred to the step down hospital. Likewise, actually it's strategic management process was done for the COVID.
Yeah. Thanks, Dr. Lal. Since Dr. Rana Singh is also with us, we are fortunate to have him, who kind of is the focal of our primary care. And sir did mention about primary care. So when we talk about, he did mention about a strong primary care, right? So can you just define what does it mean when you say a strong primary care? And when we put them in under shock, right? What happens to those primary care?
What do you mean by those primary care means?
So when primary cares come under any kind of distress or shock, how do you kind of mitigate those shocks or pressure at primary care level?
Yeah, so actually during the COVID time, as Dr. Lal Panapati said, so we utilized the primary care hospitals. So and some of the routine things are shut down, postponed, but essential services are continued, like normal surgeries we stopped, but the essential services we continued. So when it's come to primary care, we have 1,042 hospitals, primary care level. So out of that, only we used few hospitals. So others were functioning, the normal routine patients. So the system was continuing. So that's how we operated. But actually, as said, it was like planning. We mapped the geographical area, and we link the tertiary and the secondary care with the primary care settings, and map where the most cases are there. So in those areas we use several primary care hospitals. Primary care hospital we differentiate into type A, type B and type C. It's depending on the bed strength. So we mostly use the type A hospitals. So the type B and type C we kept for the normal services. That's how we did it. And now in the process of after post-pandemic, as Sir said, we are strengthening the primary care with and also clustering our system to for a future pandemic also. Like we are now mapping Apex Hospital. So Apex Hospital will be catering those primary care levels. So all the others, like within the building blocks, like said laboratory things, we have a cluster lab system. So and also now we are strengthening the supply chain. So that are the strengthening activities.
Thank you, Dr. Ransi. Dr. Lal, you want to add something?
Something. Actually, that it will be all the population will be empaneled to the clusters. So then at the Apex and the clustering hospitals will be actually given the networking, the screen the patient population, and will be entered into the and the communication also will be the facilities will be given to that empaneled patients. So then so that type of structure actually was there, not in the Sri Lanka before. So then due to the COVID situation, actually we identified the gaps of our health system. So then we are actually identifying the gaps and developing according to the identified gaps.
Yeah. One thing, actually, how we mitigate the COVID pandemic. One thing is our Director General of Health Services. We had a Quarantine Act, so he took the power. So he had the power, and all the decisions were taken by the technical group, like colleges, presidents, all the people took the decision. So that I think helped us, and also the other sectors helped, like Triforces. They helped in developing our primary care settings, building up the isolation rooms, monitoring system. So.
Thank you, Dr. Rasinghe. I think so. I think so. Thank you very much, panelists, for your insights on this area. of health system assessment and health system resilient assessment. We are running short of time, so instead of me asking questions to the panelists now, I'll open the floor to colleagues if you have got any questions for the panelists. Professor Kwan is going to leave us in the next 6 minutes or so, so we'll start with Professor Kwan if you've got any questions for him. And then we can go to Dia and Professor Lal and Professor Rana Singh. Any questions for our experts on the panel? I think so people are too close to lunchtime, so they are. Yeah, we have got Professor Mala out here. Please. Yeah. Yeah.
Resilience building, given what he said, and which I completely agree with, this need for looking at it as a whole system rather than the health system on its own. So, it's a question I've been asking myself. Where do you begin to draw some kind of a baseline or a platform of information from which you can start to measure how much better you need to be? Because at this point in time, we know no country is matching what is required.
Yeah. Professor Kwan, can you hear that question, or should I repeat it?
Can you repeat? Can you give us some?
So where do we start? If we go beyond health system and we talk about resilience as a larger construct, from where do we start? Because there are so many layers into it. So where do we start our assessment, and what are your thoughts on that?
Well, I fully agree with this dilemma. I'm an economist working in the field of public health. So the boundary of health system, for example, is always a starting point in the health system assessment. And every health policy is affected by broad socioeconomic system. But I think this COVID-19 pandemic is very unique, such that we know that all government interventions regarding this issue has a direct impact on the pandemic, but also has a very direct, not indirect, but very direct impact on the socioeconomic system. So I think for me, it's more compared to other cases, in other assessment or strengthening cases, we start with a very targeted health area, and then we can expand it. But I think in the case of this COVID-19 pandemic, we should really go hand in hand. Otherwise, we fail to have a full picture, and our approach, or only health system-based approach, does not get a full support from other sectors, and we cannot get a good performance over.
Thanks, Professor Kwan. Any more questions about Professor Kwan?
Not specific to Kwan, but generally, resilience is going to increase the cost of delivery. So how are we, and health expenditures in a lot of countries are on a minimal level. Even Sri Lanka, right, you had an economic shock. So what will be interesting to understand is how do you ensure resilience by keeping the cost and the health expenditures at the current levels? Because resilience means you're going to increase the inventories. So how are you going to manage all of this with the same cost?
Dia?
Expenditure, if you are hospital-centric, then your expenditure will go up. So I think the short answer to your question is by reforming primary healthcare system. Then you can manage the expenditure of health at an affordable level. But that being said, it's not as simple as my sentence. It requires the recap of the whole national health expenditure to be able to know the baseline first, and then you need to develop and support health technology assessment to make life-saving tools and medical devices affordable but at high quality at primary healthcare level. And then that's not to say that you do not need to increase the capacity of the health workers. So initially, there needs to be some sort of investment, a serious investment, a long-term investment on primary health care. But in the longer run, that will keep your health expenditure down. So there is never a good answer to to your question, because then you need to spend. But if you see it as an investment, then that's a meaningful spending. So it's never a cost. You spend at hospitals, in hospitals, on very high-priced medical devices. You make sure that the doctors, the specialized medical doctors, are receiving their education. But then you have this perception, we all have this perception, that primary healthcare is enough for primary healthcare to just get a meager amount of investment. That's not the case. There has to be some serious investment, but with long-term outlook. Then in the longer run, you keep your expenditure at bay.
And also that I would like to add something.
Sir.
So then actually we can empower the people, so then and educate the people. Yeah. For the emergencies actually based on the current knowledge. So it will be a good advantage actually during this COVID period even. Actually we spend some time to initiate the public empowerment, and also that identified the pre-planned health system actually should be pre-planned for the emergencies. So then we can develop, and we have also that initiated to develop the isolation centers like that. And so if such thing, not only for the COVID and the pandemics, but also for the other emergencies, actually we could have planned before.
Thank you. We have got just last question. Before you ask that question, Professor Kwan, if you are there, if you are not there, I think so he dropped off. Just thank you very much indeed. I wanted to thank you before leaving. Sir, last question from you, and then I'll wrap up the session. Yeah, please go on.
Thank you, Maulik. So my name is Sainath Banerjee, representing PSI, Population Service International. My questions related to health resilience. So, important part is that, so it has a two-component questions. One is, as Dr. Sohail mentioned, that there are around 76 indicators. Based on that, the health resilience can be assessed. So the issue is the question, I just wanted to understand what would be the source of data, number one, and how the data source should be maintained uniformity, because as we know, the people who are working in this, be it the rural area or the urban area, the data quality and source, it's kind of, always people struggle with the data. So that's my question number one. Second thing, what would be the unit of measurement? Because when we are talking about urban resilience, we are talking about across, whether rural and urban. So are we talking about that the city level to measure the resilience index, or at the district level, or at the state level? Lastly, I just wanted to have a submission when we are going for an implementation, testing out the different kind of resilience model in different context. I think it's important to have, instead of one to a model, we need to, keeping in mind, especially the urban context, diversity, we need to go for many cities with the different contexts so that there will be uniformity can be derived. Yeah. Thank you.
Thanks, Anna. Dr. Sohail is not there, so I can't answer that question. But I think so he did mention about for each and every tool they have identified data sources from where it comes from. He also did mention about the variability in terms of countries that are at different maturity level. He did not mention about rural-urban divide though, but he talked about different maturity level of country, hence for the different kind of tweaking that might be required in a tool when it is implemented. But I think so we can set up a call, and this is what the objective of GLC, that we're going to follow up with these calls and kind of make a small group which can keep on kind of thinking on these questions, what Professor Mallarao did raise, what Professor Kuhn said, how we can enhance the kind of horizon in terms of measurement indicators as we move forward. But for today, I need to thank everyone, and just a quick wrapping up on the session that we started with resilience. We started with the definition of resilience. Professor Dr. Sohail took us with what WHO is doing in terms of mapping up indicators and sources for those resilience. I did mention about resilience in terms and answering the question from the colleague also, that when you want to make your system resilient, it's good to invest in primary care, which also got seconded by our colleagues from Sri Lanka, that investment in primary care is pretty crucial for making your health system resilient. But I think so resilient, as I said, it's just, even though the word has been here since early Ebolas and SARS, I think so when we start talking measuring resilience, is a pretty new area, and we are working on indicators. And as Dr. Reddy mentioned, that lot of questions that even what Saina did ask is how do we go at a community level or an individual level, which also again we are referred to, that how do we get those construct ready as part of our health system resilient measurement indicators. This is a quick wrap up from my side. Thank you very much, everyone, for coming here. And again, thank GLC, Rockefeller to give us opportunity to be here. Thank you very much.
Maulik,
yeah.
Just stay for a minute.
Sure.
We'll have to move.
Yeah.
I'd like to recognize the people on the dais, and we have Abu Dia. Come up. Can Maulik please do the honors? Dr. Lal and Dr. Rana Singhe. I have a few very important announcements before lunch, and I'm going to take 5 minutes more of your lunch time away. We have a step plaza where we'd like to assemble all of you to show solidarity and have one picture taken. We can share them with you later. One, there is a QR code that you need to, the poll that we would like you to take. Two, please come to the Step Plaza for us to have all of you with us in our memories too. And three, lunches where the tea was served. So, QR code, Step Plaza right away, and then lunch. And we come back here by 1:15. The latest. Thank you.